much. As a clinician and researcher, I don't want to gild the lily on this and try to convince you that cardiovascular disease is not an issue for Indigenous Australian people. Nonetheless, today I'd just like to give you an insight into how we conceptualise it and what we're doing in partnership with collaborators such as ACU and Simon Stewart and Melinda Carrington and the CRE to reduce inequalities in heart disease, to actually begin to unlock why we have such an epidemic of cardiovascular disease for Aboriginal Australians and Torres Strait Islander people. And I've called my talk today The Common, which is really cardiovascular disease, and perhaps the esoteric, but not the rare for Indigenous Australians, but the esoteric condition of rheumatic heart disease that we now don't see in non-Indigenous Australians. Now I'm going to hope I'm pointing this the right way. Here we go. So I'd just like to say that the work that I'm going to be talking about today has been done by a huge number of people collaborating across multiple institutions. But in the end, first and foremost in our minds are the Aboriginal and Torres Strait Islander people who are affected by cardiovascular disease, and also these are the same people who are our key partners in actually trying to address them. So when I think about heart disease, cardiovascular disease, I really, even as a clinician who works at the pointy end of the spectrum in secondary and tertiary prevention, I really do try to always bring myself back to thinking about a continuum of care. And today I'd like us to focus particularly on primary prevention, because in my experience, I think we're actually doing a better job in actually managing people who manage to get through the front door of the hospital. But the problem is, it's the fact that people get to the front door of the hospital late, and that the number of people coming through that front door is actually not getting smaller. And it's only by actually addressing earlier presentation and actually preventing disease developing in the first place that we're really going to be able to make a difference in dealing with the challenge of cardiovascular disease for Indigenous Australians. I'd also like to highlight that particularly for Indigenous Australians, but we know for populations in general, it really is the underlying health determinants that are driving the epidemic of disease. Now, for cardiovascular disease, we know that from a non-Indigenous setting how important that is, and particularly for conditions such as rheumatic heart disease, where issues such as household overcrowding and exposure to group A streptococcal infection is really the primary driver of disease development. So today I'd just like to quickly touch on primary prevention as a key challenge in cardiovascular health in Australian Indigenous communities, and talk briefly about burden of disease, risk factors and detection, and how we need to focus on risk reduction, with a focus on cardiovascular disease in general and rheumatic heart disease specifically. I'd also like to talk about the fact that in Australia, just touch on the idea that in Australia we've developed practically an industry about documenting health disadvantage. And so we're very good at actually showing that Indigenous Australians have poorer cardiovascular health and health outcomes. But the reporting that we do have focuses very much on administrative data sets, which fail to provide the high fidelity data that we need to actually make a difference. And I think this is where research, and the research that we've been doing with collaborators, can actually provide an insight. So let's just touch on burden of disease, and I don't need to tell this audience that Indigenous Australians have far higher prevalence of cardiovascular disease. And this is particularly, and this is a recurring theme, more disease earlier age of onset. And this is demonstrated here with age stratified prevalence of cardiovascular disease. The other thing which is key is that remoteness is an additional risk factor for driving cardiovascular disease. And we know that many Indigenous Australians live in outer regional and remote Australia, but we shouldn't forget that 57% of Indigenous Australians actually live in our large cities and our inner regional centres. So when I'm talking about cardiovascular disease, I'm not just talking about people living in remote communities, I'm talking about people living in our cities as well. Let's go from the broad to the higher fidelity that information that we've mentioned. And this is just some piloting data that we've recently done in collaboration with ACU in a study looking at cardiovascular disease and risk factors in Indigenous Australians. And in this small group of just 200 people, we've actually undertaken detailed echocardiographic studies looking at heart function. Now, accepting that we're not all cardiologists, what I would like to point out here is that in this population we have lots of people with heart failure, and really what we were seeing was about 10%, 1 in 10 of this relatively young population with a median age of 40 actually had systolic heart failure. So this is 1 in 10 relatively young people having heart failure. We also saw that markers of other markers of heart health, and particularly a marker of left ventricular hypertrophy, which goes along with hypertension, were also elevated, with around 8% of this just community-based cohort having increased left ventricular hypertrophy. And perhaps more importantly, we're also seeing the very early and subtle changes of heart disease in this population, where we're seeing very subtle changes in the size of the heart and the ability of the heart to pump well, where up to 2/3 of people are beginning to show the earliest signs of the heart actually not functioning normally. So what we're really saying is that we know that there's a lot of people presenting with heart attacks and heart failure and stroke, but really, when you look much closer at this population, you can see a far greater proportion of people have the earliest signs of disease, and it's this group of people where actually intervening can make a difference. So if we look, I think, specifically at acute rheumatic fever and rheumatic heart disease, it's worthwhile just touching on exactly what these conditions are. So acute rheumatic fever is a condition that for non-Indigenous Australians has really been assigned to 100 years ago. But it's a condition associated with an abnormal immune response to a common bacteria that lives at the back of the throat or on the skin called Group A streptococcus. And in susceptible individuals, which usually account for 3 to 5% of any population, these people can actually develop this abnormal immune response that's typically associated with fever, sore joints, and also inflammation of the heart. Now, what we say about acute rheumatic fever is that it licks the joints but it bites the heart. And what this means is that a lot of the problems of acute rheumatic fever, the joint pain, the fever, will resolve spontaneously. But the thing that doesn't resolve spontaneously in about 1/3 of people is this inflammation that occurs in the heart, and particularly has a predilection for the valves of the heart, and in this case the valves on the left side of the heart, which are called the mitral and aortic valve. And this just shows here on this figure that about 1/3 of people, well, about half of the people who actually get acute rheumatic fever actually develop inflammation of their heart valves, and about 1/3 of these go on to get progressive scarring of their heart valves that can lead on to things such as heart failure, infections of heart valves, and a need for surgery. Globally, if you look at Australia, and this is WHO data, globally if you look at Australia, which is here in the orange, our levels of rheumatic heart disease are not high, but of course this fails to account for the 2.5 to 3% of Australians who are Aboriginal or Torres Strait Islander. And if we look at this group of patients, and we undertook a survey of 5,000 children, if you look at 5,000 children, with about 4,000 of those being Indigenous Australians, what you see is about 1% of the Indigenous Australian population have rheumatic heart disease, of which only half of them are actually known to the healthcare system. And when you consider the implications of having valve disease at such a young age, this is, as I say, an esoteric condition to all of Australia, but a very important one for Indigenous Australians. So in summary, regarding burden of disease, I think for Indigenous Australians, we see high levels of established cardiovascular disease, but even more worryingly is we see very high levels of early and preclinical disease. And for rheumatic heart disease, we see a relatively small but significant proportion of children with rheumatic heart disease, of which only half of it's known. So let's move on to risk factors and detection. And in the interest of time, I'll just move quickly through these. But I don't think, again, it's surprising that Indigenous Australians have high levels of smoking, obesity, elevated blood pressure, and dyslipidemia and low levels of physical activity that would tend to explain, at least on first looking, the high level of cardiovascular disease that we see. And if we look again back in our Birch cohort, this initial cohort of now 400 Indigenous Australians, we see the same levels of high cardiovascular risk factors. So high levels of smoking, 2/3 of people smoke, a quarter of them are obese, around a quarter of them have evidence of elevated blood pressure, and high levels of self-reported diabetes and kidney disease. But I think what is really quite interesting in this group, if I can press the right button, is that when we actually look at what their cardiovascular risk, calculated cardiovascular risk is, it's actually relatively low, and it does not explain what we see when we actually see the level of cardiovascular disease in this population. And I suppose this is the second point that I'd make, which is if there's a lot of disease, existing risk factors fail to actually explain the risk in this population. So if we are going to understand primary prevention and risk detection and intervention, we probably need to begin to ask ourselves, are the same things driving cardiovascular disease in non-Indigenous Australians the same things driving it in Indigenous Australians? And in rheumatic heart disease, I suppose just to again point out some of the challenges we have, if you remember I said about 0.9% or about 1% of the population had rheumatic heart disease. When we actually went and had a look, what we found was about another 4% of the population actually had changes that could be suggestive of the earliest possible evidence of rheumatic heart disease. And I'll explain why that's so important, because with rheumatic heart disease for Indigenous Australians, we may be actually not worried about 1% of the population. We may be worried about 5% of the population. So I'll just move on now and just summarise that as far as risk factors go for cardiovascular disease, I think we've got high levels of traditional risk factors in Indigenous Australians, but this still doesn't explain the overwhelming burden of disease we see. And we've also begun to unpackage rheumatic heart disease, that we're beginning to see that what we thought was a rare but important condition affecting about 1% of the population may actually be affecting up to 5% of the population. So now let's move on and finish off with what I think is the most important thing. You can talk about burden of disease, you can talk about understanding mechanisms of disease, but in the end, what we have to do is actually reduce the risk of developing disease. And how do we actually do this when we're faced with these challenges of a substantial burden of disease, lots of risk factors that don't explain the risk that we have, and high levels of early and preclinical disease? And it's here where I'd like to just touch on the work that we're doing in association with collaborators to actually begin to identify and intervene in these areas. So regarding cardiovascular disease, what we're actually found is that what we need to do is target traditional risk factors, but we know that targeting the risk factors we know is not enough because we have an ongoing burden of disease. So as part of the Birch study, we're trying to understand the unexplained risk that's driving the cardiovascular disease epidemic in this setting, and to identify new targets for intervention. And so we're working to develop a prospective cohort study that will utilise the data we have in these initial 400 people to actually expand this to 2,000 Indigenous and non-Indigenous Australians, and to identify potentially new risk factors and early disease markers that will be a potential target for primary and early secondary prevention. At the same time, in rheumatic heart disease, there is no doubt that the primary driver is actually health determinants, and the primary answer will be primordial prevention, dealing with particularly with environmental disadvantage and household overcrowding. That being the case, we know that while we're waiting for this demographic and health transition to occur, what we need to do is actually better identify acute rheumatic fever. And so we're undertaking a number of projects trying to better diagnose acute rheumatic fever and identify those people who are most likely to go on to develop rheumatic heart disease. Because we know in that population, if we can deliver regular prophylactic antibiotic therapy, we can stop acute rheumatic fever leading to rheumatic heart disease and the complications of heart failure, endocarditis, and needing surgery. Even if we do that, there are a lot of people out there, and we've already identified up to 1 in 20 kids who already have evidence of rheumatic heart disease, and we can't leave those people behind. So what we're also aiming to do is identify how we better deliver secondary antibiotic prophylaxis, and also how we better manage advanced valve disease. But the really encouraging thing, I think, is that if we look again at the challenges facing us, although we don't want to see ourselves as the ambulance at the bottom of the cliff, what we do see is that in the unfortunate setting where Indigenous Australians do actually require heart surgery, the heart surgery we provide in this country is excellent, and the health outcomes that we're seeing following surgery for rheumatic heart disease are the equivalent between Indigenous and non-Indigenous Australians. So we don't want to have to actually focus on acute curative or tertiary prevention, but we should at least take heart that as a country we are making sure that if we can't prevent disease, we can still provide excellent health care for Aboriginal Australians and Torres Strait Islanders. So thank you.